So I work in the cardiovascular disease team for HYNEC, and as many of you may know who are logged onto the call today, 690 deaths a month are attributed to cardiovascular disease. That's 1 in 5 deaths in some areas of the region. So our CVD prevention portfolio programme focuses on hypertension, chronic kidney disease, CKD, familial hypercholesterolemia, FH, and lipid optimization and management in predominantly secondary prevention, but we do look into primary prevention as well. Yeah. So why do we do it? Obviously, we want better health outcomes for our patients across the region. So our vision is to reduce the risk of CVD and lower the incidence of related events. We want to work with our partners as well. So again, working in collaboration, which is why we've kind of invited Jack along today to work in collaboration with Jack and of course Catherine. And that helps us develop tools and pathways and services that can be adopted across the region. And there's also economic growth benefits. So we aim to drive a positive financial impact, enhancing services and efficiencies, and fostering those partnerships with industry and supporting the adoption of innovations, and obviously reducing health inequalities. So obviously the CVD team sits in the health programme, and we're committed to working with health organisations and community leaders, local populations, to ensure that we can kind of drive that innovation and reduce health inequalities. So, high blood pressure is the leading cause of preventable death worldwide. And through treating high blood pressure with antihypertensives, 1 heart attack for every 100 patients and 1 stroke for every 67 patients is prevented. Okay, so I just thought I'd kind of put those statistics out there for you. The references are at the bottom if you kind of want to have a look at those as well. The high blood pressure, what are the risks? Why are we talking about high blood pressure today? So high blood pressure, obviously hypertension, it's one of the most important risk factors for cardiovascular disease, and it's very common, especially in kind of older adults. If blood pressure is too high, it can cause damage to blood vessels, and there's usually no symptoms, so people don't realise that they have it. It can lead to serious problems such as heart attacks and strokes, like we said on the previous slide. But lifestyle changes and blood pressure medications can help to keep people healthy. Okay. So things that can increase someone's chance of having high blood pressure. So some of these things we can do stuff about. So those modifiable risk factors and some that we can't. So age, so you're more likely to get high blood pressure as you get older. Having close relatives with high blood pressure. Ethnicity, there's certain ethnicities that are at higher risk. And these are things that we can change. So unhealthy diet, especially a diet that's high in salt, being overweight, if you're a smoker, if you drink too much alcohol, or if you've been stressed for over a long period of time. So with blood pressure, we need to know our numbers. So this is the current NHS NICE guidance. So people aged under 80 years of age, it's considered high if the reading is 140/90, and that's when it's checked by a healthcare professional, or 135/85 when it's checked at home. If you're aged 80 or over, BP is considered high if it's 150/90 by a healthcare professional, or 145/85. However, it's important to remember that an ideal blood pressure is under 120/80. Okay, and those 140/90, that's when we're kind of looking to treat. And between the kind of 120/80 and 140/90, that's when we would look at those modifiable risk factors. Okay. So what can you do? So you can use searches such as CDRC. There's other search tools out there as well, to help identify patients who are not treated to target. Take accurate measurements and provide patients with self-management information, including the Know Your Numbers guidance. Take make every contact count approach, so a MEC approach to hypertension. So we do recommend that all patients with CVD, CKD and diabetes, that they get an annual blood pressure check as well, and follow the hypertension annual review guidance. And that includes taking a urine sample and a HbA1c test as well. Okay, which kind of leads me on to a new program that we're supporting in High and it's called Are You Taking the P? And this is about blood pressure linked with chronic kidney disease. So there's actually, again, there's no symptoms for CKD in the early stages. And it's commonly caused by other conditions that put a strain on the kidneys, such as hypertension. So we're currently actually looking for practices to participate in our campaign called Are You Taking the P? And this is to co-design materials to remind staff to take their urine samples for the UACR, which is the CKD test. It'll take roughly just over an hour for my colleagues to kind of come to the practice and kind of have a chat with you about that. And apparently there's a prize draw as well if anybody's interested in kind of taking part in that campaign. If you would like to contact my colleague Karen, so Karen Verrill at healthinnovation.org.uk. Okay. So, and coming soon as well, so we are redesigning some of our resources on our website. So again, it's about making that every contact count and taking the comorbid approach to CKD and CVD related risks. Offer annual testing with CVD, obviously for hypertension and diabetes, a blood test, a urine ACR, UACR, and both tests are required. We have developed some process maps, which will be on our website soon. Okay, so keep an eye out for those. Okay. Now I'm going to hand over to my colleague Jack, who is the project delivery lead for the ICB. Thanks, Jack.
Brilliant, thanks Tracy. I'm just going to take control here, make sure that the slides work. Right, okay, brilliant. Hi everyone. So as Tracy said, I'm Jack. I'm a project delivery lead in North East North Cumbria ICB, covering cardiovascular disease. So that includes prevention side, which is quite relevant to what we're talking about today, but then also things a lot further along on the pathway, such as cardiac rehabilitation and heart failure as well. But I just wanted to start with just to give you a bit of an overview of where the ICB's priorities are in line with high blood pressure at the moment in terms of the type of work that we're doing and the kind of future plans as well. And then I just wanted to cover a little bit around CVD prevent data, particularly just to give you an overview of how the ICB performs on things like hypertension treatment to target, etc. So yes, I previously was aligned to something called the clinical networks, which some of you might be familiar with. Since the 1st of April, there has been changes within NHS England and the ICB. The clinical networks and what was a CVD prevention network technically isn't in existence anymore, but the ICB has created a long-term conditions programme which is focused on some of those, I guess, key conditions which previously might have been led by the networks, and one of them is cardiovascular disease. We've also got diabetes under long-term conditions and respiratory as well. But as I mentioned, I'm the one that kind of leads on the cardiovascular disease stuff. And the work streams are all around aligning with what the national priorities are for these conditions. For example, we have key metrics that were measured on by NHS England, but then also what the ICB's priorities are as well for North East and North Cumbria. So the ICB has recently developed what they call a clinical condition strategic plan, which that's available on the ICB website if anybody wants to look at that, or we can send it out as well. But ultimately, the strategic plan is providing recommendations and priority areas for our region of what the ICB wants to work on. And here they are for cardiovascular disease. And you can see that we've got 4 kind of key headings here for the recommendations. And relevant to this talk today, I'd say take particular attention to case finding and prevention. So as you can see for case finding, first of all, that's around proactively case finding hypertension, AF, diabetes, hyperlipidemia, etc., etc. So obviously there is a lot of case finding for high blood pressure, which happens across the region, the work that's done in GP practices, the work that's been done in community pharmacy, and also community projects which happen as well. So we need to obviously find the cases in order to treat them and reduce risk of cardiovascular events happening in the future. So case finding is a big thing and a priority within the clinical strategy. But then prevention, and by prevention, obviously you have that primary prevention in terms of lifestyle stuff, but it's also prevention of cardiovascular disease through treating hypertension, AF, and lipids. So if we treat hypertension to target and get people's blood pressure within a healthy range, whether that's through lifestyle change or appropriate medication, which is done at the GP practice, we need to ensure that we treat high blood pressure to target to prevent case, heart attacks and strokes. You've got treatment and rehabilitation as well, which is more relevant to things further along the pathway. Again, the focus today around high blood pressure is kind of the earlier case finding and prevention stuff. So just to touch upon some national priorities, which I mentioned before, were measured by NHS England. I've highlighted the one in yellow there, which is part of what we call the planning guidance. So it's a national target of increasing the percentage of patients with hypertension, so treating patients with high blood pressure to target ultimately, and we want the percentage, the aim is 80%, and I'll come to how the ICB performs on that soon, but we generally do pretty well. But the aim by March 2025, so next year, is that the ICB reaches 80% of patients treated to target. You've got other metrics there around lipids and addressing health inequalities, which is obviously relevant, but the focus is blood pressure today. And the other ones below aren't too relevant because they are for cardiac rehabilitation and heart failure. But at the moment, the ICB is working on an updated CVD action plan to highlight some of the key work that we're involved in, whether that's directly from us, whether it's working with Health Innovation, working with local authority, working with secondary care, primary care, and so on. But the ICB is kind of finalising plans for particularly the rest of the year and next year as well. So once we've got those finalised, we'll be in a shareable position for that also. But just to highlight some of the recent pieces of work that we've been involved in at the ICB on blood pressure is we have a blood pressure kiosk project. Now, where this started was there was an expression of interest process from NHS England to apply for some funding. Our ICB was successful in getting that funding. And then what we needed to do was understand of how we were going to deliver the project. And the aim was to ultimately improve case finding in communities which might not typically, visit the GP practice regularly. So by putting blood pressure kiosks in community centres, we thought it would be a good opportunity to case find. So what we have is we have 6 of these kiosks across community centres in North East and North Cumbria. We have 2 in Middlesbrough, 2 in Hartlepool, and 2 in North Tyneside. And ultimately, these community centres are based in more deprived areas, so IMD deciles 1 or 2. And we're also hoping to target more ethnic minority communities as well. For example, one of the centres in Middlesbrough is NUR Fitness, which is a women's ethnic minority centre. So quite a high proportion of engagement that we have there. So I guess the aim of the project is all around improved case finding, but particularly considering health inequality. So targeting deprived areas and ethnic minority communities as well. So the blood pressure kiosk is really simple to use. You literally pop your arm in, you press start, and it'll take your blood pressure. But we just don't have the kiosk there. We also train blood pressure champions to support the project, which is usually staff that are based within those centres. So those staff have been trained to, be able to give advice on what the numbers mean, appropriately signpost, take a mech approach. So where we trained, it's around 82 blood pressure champions so far, which are obviously supporting use of the kiosk on the project, encouraging people to use the kiosk, etc. So we're doing a proper evaluation for the project in March next year. We'll be at the 6-month point period, but the project is running for a year, so it will run until September. So again, once we have a final evaluation for this, we'll be happy to share. But as I say, it's all around trying to improve case finding of high blood pressure in more deprived areas, ethnic minority communities. And we thought a way that we might be able to achieve that was by putting these kiosks in community centres so that it's easy accessible to get your blood pressure done. You don't have to go to your GP practice. You can get it done at a community centre with a blood pressure champion, or just use a kiosk yourself. I think somebody's taken control there when they shouldn't have. Caroline, I think you might have taken control by mistake. There's the slides gone. Tracy and the team are, if you were able to reshare the slides, I can take control again, because I think they've gone off now. Typical Teams issues happen all the time, don't they? I'm just reading some of the bits in the chats whilst the slides get back up as well. Yeah, the kiosk is a small pilot at the moment, so if it evaluates well and it's successful, I imagine there might be scope to increase it further. The reason why we chose those 6 areas, well, those 3 areas and the 6 kiosks, is it was all based around data. So we looked at obviously health inequalities, data deprivation, and then also the performance of some of the key CVD indicators. So how are the local GP practices performing on hypertension treatment to target, prevalence of hypertension, etc. So the selection of those areas are all based on data, and then we did an expression of interest to public health and community centres to help us get community centres on board as well. Because it's mainly community hubs where they've got a range of services in there. They've got library services, job centre services, sometimes food bank style stuff. So they are placed in good centres to get the kind of populations that we want. But I think there will be scope to look where else could we go with these kiosks if funding becomes available, because there's lots of scope to do stuff in the community and target the people that we need to. Right, I've spoken enough about that anyway. Let me take control and I'll move on to the next slide. I can pick up any questions after as well or towards the end. Yeah, some other bits in terms of what doing the ICB on blood pressure. So we've tied in with a couple of national campaigns recently. So Know Your Numbers Week was early in September. So we had a bit of a toolkit which was sent out to partners to promote stuff on social media. We've done some videos. Similarly, we did that for Cholesterol Month, which was October as well. We've just got some planning a piece of work, some targeted social media as well to basically push out some social media messages around blood pressure and cholesterol to the populations most at risk, so generally those at 40 plus, doing some targeted social media ads really to understand the impact of those. We've also said about doing it in more deprived areas as well. So we've just started getting the motion started with that, and yeah, we'll be measuring the impact of what engagement we get with those posts as well. Case studies. So actually, I think I've seen one of the pharmacists on, which helped us with this on the call earlier. So we've recorded a video recently with some pharmacists and a GP, which we previously worked with on some improvement work in their PCN, who previously had a clinical leadership team, which involved Catherine, who's speaking later. And what we did is we offered support to practices where needed to help improve their numbers around diagnosis and management of high blood pressure, cholesterol, etc. And one of the PCNs has kindly done a case study video for us to tell of how they've improved, what work that they've done in the practice to share learning. So that should be ready fairly soon. The comms team have just been chopping down the video because it's quite long at the moment. So we're just doing the final edit, so that can be shared once it's done also. And then I just wanted to touch upon the Learning Academy and the MEC Gateway, which has been developed by the ICB recently. So the Learning Academy, there's just a bit of a snapshot here on the screen, is basically a learning platform which hosts training and education, basically. And it's not just cardiovascular disease, there's lots of different topics on there. So I'd encourage you to use the QR code or go ahead on the link to see what topics there is on there. But we do have a cardiovascular disease page, which at the moment is mainly signposting to training that is out there. So there's lots of e-learning and resources already out there, which you can, which clinicians can use. It's not just relevant to clinicians also. If you've got a general interest in CVD, some of the other stuff will be relevant there. But it's ultimately to host training and learning. So we would encourage you to have a look at this. And it's still in its early days. It's only just launched. So there will be building content as we progress through things. But yeah, just have a look and get a feel for it. As I say, it's a great resource to have. Anybody can access it. You don't need to be in the NHS or a certain job. Anybody can sign up and access the learning. And just to mention as well, for those that are familiar with Make Every Contact Count, MEC, that is also an online resource for particularly around signposting to services. So there is various topics on this website as well, and we've recently developed a cardiovascular disease topic tile. So if you go onto there, it gives you kind of conversation starters around brief advice. If you've been trained in that through MEC, you'll be familiar with that if you have done the MEC training, and also signposting to different services around that's relevant to cardiovascular disease, and a bit of general information of what cardiovascular disease is, what should you know, what should your blood what's a healthy blood pressure, what do the numbers mean, and so on, just general information and signposting to local services as well. Right, brilliant. Then I just wanted to touch upon a little bit of a regional hypertension data, just to give you an overview of how our region does on hypertension. So just to start, this is just some prevalence data around hypertension, which is showing us the estimated prevalence of hypertension, but then also the actual prevalence, so that when we can work out, right, well, what is the gap between that? Because that would suggest what the hidden prevalence is, so the amount of cases that we haven't found. Bear in mind that this estimated prevalence statistics that we've got is a few years out of date, so I would take it with a pinch of salt. So it's from the Health Survey from England. I think it is a couple of years out of date, whereas the actual prevalence statistic that we've got there, that's quite up to date. That's pulled every month from GP systems on the dashboard that we've got. But nevertheless gives us a bit of an indication. So as you can see here, overall the North Cumbria, there's a 5.9% gap between the estimated prevalence and the actual prevalence, which would suggest there's 5.9% of cases that we haven't found. If you look at between place-based areas, I think it's quite small on my screen now, but I think North Cumbria had the highest gap or hidden prevalence, if we call it that. Which would suggest that there's more work to be done around case finding. But as I said, the estimated prevalence statistic, the source is a bit out of date. So nevertheless, as I say, it gives us a bit of an indication. But then I just wanted to go through CVD Prevent. Some of you might be familiar with this. You might have been on CVD Prevent before, but it's a data tool which has been brought out the past few years, and it's had continuous developments and it keeps growing. I personally find it really useful. I think it's a great tool. It's not that hard to use once you get familiar with it. I know any data tool, it can be a bit, what's the word, a bit daunting at first, but once you've had a look, it is a really useful tool and quite easy to use. And I've just pulled some of the screenshots of the hypertension data on there. So this is showing us from an ICB perspective where we sit on our blood pressure monitoring. So this indicator is basically looking at the patients with GP recorded hypertension. Have they had a follow-up blood pressure reading in the preceding 12 months? And our ICB is a second from top, so we do pretty well on this. And it's been like this for the past few data releases as well, over a year definitely. So we do quite well, but there isn't necessarily a target for this indicator. But anybody with GP recorded hypertension, we want to make sure that we're following up, they're having their annual reviews and so on. So we need to make sure that we do get our people in for our annual reviews, which I think Catherine might touch upon, and Tracy briefly mentioned it earlier. Just a bit of an overview of how it varies between place-based areas. County Durham does the best on this. Some say worse, but to be honest, there isn't significant difference between each area. The graph make it look like that, but Sunderland will be around 87.5% and County Durham around 92. So you haven't got massive differences here, but just to give you a bit of an overview of how the place based stuff varies. And if you can see this, it's really small on my screen now, but I do know what the data is saying. So we're just looking from the CVD Prevent tool here from a deprivation angle. So you can see that the most deprived generally perform the poorest on this, and the more affluent populations perform better, so are better getting the blood pressure reviewed, which we do see that trend in quite a bit of the CVD data usually. And the next one just touches upon ethnicity as well. I can't zoom in on mine too close, but again, I know the data, and it's usually that whites come out on top for this in terms of performing the best, and usually more mixed ethnic minority groups, blacks, Asians, are a little bit lower. So you can see kind of the gap between different ethnic groups. And this one is a really interesting one next. So we like to look at the hypertension treatment to target. So those people that have GP recorded hypertension, are we treating them to target? So getting their blood pressure into a healthy range. And this is an indicator that we are measured on and have a target from NHS England, which I mentioned earlier, is 80%. We do the best in the country for this, which is excellent news. We have done for a while now, so there's a lot of brilliant work going on with our region, which is all down to yourselves on this call for doing this work. So a big hats off to you all and motivation to keep going with this, but we're still not meeting the ambition is the main thing, which means there's still more work to be done. I can't read this right because it's really small, but I think it says how many people that aren't treated to target in our region that we need to treat to target. I think we're around 71, 72% overall as the ICB, and the target is 80. So by March 2025, so still work to be done, but big congrats that the ICB, our region, North Cumbria, is doing well on this. County Durham on top again for this blood pressure indicator, North Tyneside towards the bottom, but as I've mentioned, this graph makes it look the difference and look bigger than what it is. I think we're around 67 for North Tyneside and about 73 for County Durham. So again, not huge differences. And from a deprivation angle, again, it's the same as what I mentioned earlier. Most deprived perform the poorest, more affluent perform the highest. And on the ethnicity one, this one's a bit clearer with the graph. Our black groups perform the poorest on this, and it is usually blacks with the highest risk of CVD as well, and generally highest prevalence of hypertension. When you go into CVD prevent, you can see this quite easily. You can hover over the little dot marks, and it tells you which groups you are. This is just screenshots that I've got here, but I do encourage you to have a look on the data tool and have a play around because it is really user friendly. You can get a lot of data from it. I've just pulled deprivation and ethnicity today, but you can look at age group, sex, learning disability, and SMI as well. And there are lots of other different indicators on there. They're just a couple of hypertension ones I pulled out for the purpose of this. And just to lastly mention that there was a quality improvement pack sent to ICBs, which includes some of this data and also some tips of particularly how GP practices, PCNs can, improve the work around this. So some top tips around, running searches, finding the right people that you need to treat to target and so on. So we can share that data pack and those tips with these slides as well, no doubt, so that people can refer to that and take any information that might be beneficial for them. Right, I think it's handing over to Catherine now. So I'm just going to, if somebody wanted to read, yeah, somebody's taking control. Thank you.
That's great. Thank you, Jack. Thanks for sharing that detail. It's really important for us to see, the fantastic work that everybody's doing, but also there is still work to be done. So my name's Catherine Tucker. I'm a pharmacist in a lipid clinic in North Tyneside Hospital. I've spent the last 12 months working a day a week with Jack and the ICB CVD prevention team. And as Jack said, we use the CVD Prevent database to see which areas and which PCNs and practices needed some extra support. So the CVD Prevent data is a great source of information, and if you haven't had a chance to look at it, as Jack said, do have a go. So my talk is going to focus on the clinical aspects of blood pressure and the guidelines, and just to put it into the national context. We're still taking an ABC approach. We're still focusing on atrial fibrillation, blood pressure, and cholesterol. All of these things, treating them to target will reduce heart attacks and strokes, and it's important that we don't forget the other elements to this. With AF, this information is from the British Heart Foundation, and they've suggested that there's over 200,000 people who have undiagnosed AF. And that obviously puts you at a great risk of a stroke. We're talking about high blood pressure, lots of people with untreated high blood pressure, and around 50% of heart attacks and strokes are associated with high blood pressure. And the other element to this is high cholesterol. So we know there's about 43% or so of people whose cholesterol is above the national guidelines. And again, that can have a contribution to heart attacks and strokes. And the next slide, please. So this slide is taken from the ESC guidelines, and this just kind of gives us an indication of how complex blood pressure is. It's affected by lots of different things. So the four central circles give us an indication of the different clinical factors that can impact on blood pressure. So it can have renal causes, hormonal causes, vascular causes, neural causes. But in addition to that, there's this extra layer of other factors that can impact. So there's some element of genetic factors. So if you've got high blood pressure in the family, there's a high chance that you may also have high blood pressure. There's things like environmental factors, so things like air pollution, noise pollution, climate can impact on blood pressure, and things also socioeconomic and psychosocial factors. So things like stress, I think Jack or Tracy mentioned this, stress and low socioeconomic status and social deprivation. So we know that people in these groups don't access healthcare in the same way that other people do. And so it's really important that we try to highlight this group of patients and do what we can to give extra access to, blood pressure checks and make sure we're treating them to target with the medication that we've got. The other aspect to blood pressure and also cardiovascular disease in general is the behavioural factors. And so we know physical activity impacts on your risk factors, the sleep quality, dietary patterns, the amount of sodium that you eat, alcohol, obesity. So this blood pressure is a very complex problem with lots of different factors that some of which we can change and some of which we can't. On the next slide, the other way. Thank you. So, as I said, around 50% of heart attacks and strokes are associated with high blood pressure. So it's really, really important that we identify it and treat it, because we know with untreated blood pressure at increased risk of heart attack or stroke, and also long-term complications. So this slide, we've just got some details about the end organ damage that can occur from long-term untreated high blood pressure. So it affects the vessels. High blood pressure damages your vessels, and this can then affect all these different organs on the slide here. So you can have eye damage, heart damage. It can lead to heart failure, MIs, AF. We know it can have an effect on your kidneys, your kidney function, ultimately leading to renal failure in the worst case scenario. It can affect your large and medium arteries, so it can contribute towards atherosclerosis, vascular calcification, and it has an impact on the brain as well. So it can affect cognitive impairment, vascular dementia, ischemic stroke. So lots of reasons why we need to reduce people's blood pressure as much as we can. It also gives us an opportunity to talk about these different health and well-being services that we've got, and signpost people to do what they can in their diet as well. Next slide, please. So we know we've got people out there that are untreated. We know about some people who've got high blood pressure. We know that there's people that we don't know what the blood pressure readings are. One of the things that we can do within the GP practices is use some of the digital searches. So our local group is called the Clinical Digital Resource Collaborative, and this is a group of clinicians from the Northeast. It's led by a GP, Gareth Forbes, who's based in Durham, and he has a clinical team of other GPs and system managers as well. And this group have designed some fantastic searches. Today we're talking about hypertension and blood pressure, but they've looked at lots of different clinical conditions as well. So on this slide, I've just given a couple of examples of the searches you can use. On the left, there's examples of case finding searches. So these searches help to clarify your hypertension register. So there may be some patients within your practice that have had a blood pressure reading which is above what you would think is the threshold, but they haven't got a diagnosis of hypertension. So this particular search can highlight a list of patients in that category, which then enables you to follow that up and have another blood pressure check, or see, what you need to do in terms of deciding if they may have hypertension or not. There's other searches within this case finding that can identify people who are on what you might think is an antihypertensive medication, but they're not coded for hypertension. So again, another list for clarification and for follow-up. On the right-hand side, there's some search examples of how to manage hypertensive patients, so people who've got a hypertension diagnosis, but are not to target. And so it breaks down the list into different priorities. And for example, priority 1 are a group of patients who are overdue a blood pressure check, have suspected poor concordance, and have a reading within the system that's greater than 20 over 10 milligrams of mercury over the NICE target. And there are lots of different digital searches available. So there's we've got the QOF searches actually built into the system, Zenus and System 1. We've got Ardens, we've got UCL partners. But the great thing about the Digital Resource Collaborative is that they have very specific searches which can help you break down the large lists. Particularly if you work in a large practice, you may return, the QOF search may return a list of thousands of patients, which is very difficult to work through in terms of the numbers, and the CDRC just helps you prioritize, by highest risk, by priority. So it's a great resource to have. Next slide, please. In terms of the blood pressure target, so once you've found your list of people that you either need to do a blood pressure check on or who you need to treat for hypertension, you've diagnosed hypertension and now they need treating, the guideline to refer to is the NICE CKS hypertension treatment pathway. And within that, it's 2 sheets of A4, and it's a great summary of the first page tells you the thresholds, the treatment thresholds, and the second page tells you about the actual medication to use and the treatment pathway. So it's really important to be familiar with the numbers, and really important that all members of your team are familiar with the numbers. So it may be within a practice that the healthcare assistants are actually doing the blood pressure checks. So really important that they know what numbers they're looking for and when to refer on for, home further monitoring or home blood pressure monitoring, or if somebody needs treatment. And the key thing about treating to target, it's really important to get people on treatment, but often with high blood pressure, people need multiple medications. And, so you need to titrate the doses of the initial medications. You might need to add in further medications and titrate those. And sometimes people do get side effects. So the difficult thing we have with blood pressure is often people don't know they have high blood pressure. It's kind of symptomless. And then we give them medication to get the numbers down, and then they start to get side effects. So it's really important for us as healthcare professionals to have conversations with people about their medication. There's some information from there's a NICE guideline on medication adherence, which suggests that 50% of people don't take the medication as we prescribe it. So it's just something to bear in mind when we're titrating doses and adding in more medication. It's really important for us to ask the patient if they're actually taking the medication. Next slide, please. So this slide just is the second page of the NICE CKS guideline. It just talks about the different medication options that are available. It's an easy to follow flow chart. The first step is determined by whether you've got hypertension with type 2 diabetes, or if you're over 55, or if you're of Black African or Afro-Caribbean origin. And that determines whether you start with an ACE inhibitor or an ARB, or you start with a calcium channel blocker. And both of those groups of medications need titrating, and also a check of the kidney function, and obviously further monitoring of the blood pressure numbers. And then if you're not achieving target, the next thing to do is move to step 2, add in another medication. And as you can see, there are different options to add in further medications. By the time you get into stage 4 and you're still not achieving the blood pressure target, it's really important to bear in mind that there might be something else going on. So somebody might have resistant hypertension, and in that case, if you're a non-medical prescriber, so the pharmacy team prescribers or the nurse team prescribers, it's really important that you're starting to ask questions at that point. or maybe a little bit before this point, to understand what else might be happening. Obviously, the guideline itself says here, make sure you check adherence, make sure the patient's being honest with you and telling you whether or not they're taking the medicine. But if they are taking all of these medicines and they're still not to target, we need to start thinking about secondary causes. And it may be you need to speak to your GP colleagues about this to help understand what other things might be happening. So there might be primary hyperaldosteronism, there might be renal artery stenosis. Different clinical conditions can actually impact on the blood pressure and make it difficult to treat just by using these medications. Next slide, please. So there's lots of clinical trial data out there. We've had blood pressure medications for a long time, and there's lots of clinical trials. We know reducing blood pressure reduces cardiovascular disease events. The first slide on the left, we've got data to suggest that the cardiovascular disease mortality risk doubles with each 20 over 10 milligrams of mercury increment. So, for example, if you've got a blood pressure of 175 over 105, you're at 8 times more risk of dying and having that event. On the right-hand slide there, we know that long-term antihypertensive therapy significantly reduces cardiovascular disease events. And again, there's evidence to show that reducing the blood pressure can reduce strokes by up to 40%, heart attacks by up to 25%, and diagnosis of heart failure by over 50%. So really, really important, and lots of clinical benefit by doing this work. And really improves patient outcomes as well. Next slide, please. So the final slide, which is great, I'm on time, we've got some opportunity for questions as well. So the key messages that we're keen for people to take away today: it's really important for us to identify high blood pressures, and we can do this by offering the blood pressure checks. As Jack mentioned, there's different projects occurring in community centres, and there's also the community pharmacy blood pressure checks and pharmacy first. So really important that we make use of these checks. There's digital searches that we can use in primary care within the clinical systems, and the CDRC is a great example of specific searches that are very useful. And this just helps us to prioritise the higher risk CVD patients. There's lots of people out there with high blood pressure readings, and we just need a way to focus on those higher risk patients to reduce their risk of having a heart attack or stroke. Really important to treat the high blood pressure and optimise the medication. So lots of opportunities to titrate medications, add in other medications. And this work is very much protocol driven, so it's lends itself really nicely to different skills within the team. So really important to think about your different team members, who can run the searches, who can have the titration conversations, who can actually prescribe new medications. And then it's also important to think about making every contact count. I think Jack and Tracy have both mentioned this, but just reinforcing the message, really. There's lots of things people can do, really important to reduce the amount of salt people are eating, reduce weight, reduce alcohol, stop smoking, and try and increase the physical activity where possible. And there's within whatever setting you work, we as healthcare professionals, we can signpost people to different support agencies that can help people with these different things. So obviously there's the stop smoking services, there's the weight loss services, various different services. So important to have that list of your local services to hand and make sure everybody in your team is aware of it. So if you do get an opportunity or a conversation with somebody, you've got that information to hand, and you can, try and have that motivating conversation and refer them on to those appropriate services. And the final message there is just about communication of cardiovascular disease messages across multiple sectors and professionals. So it's really important that we work together on this task. The figures suggest that the North East is doing very well, and which is fantastic, but we've still got more work to do. And so making sure that we all team members are aware of the process and aware of the guidelines, and communicating those positive messages. So that's my talk finished. I think, sorry, last slide, just about resources. So there's lots of different resources available with different websites have got different educational resources and different patient leaflets as well. So these are just a few of them on this slide. And then I'll hand back to Tracy to lead the questions.
Thanks, Catherine. I've just got a couple more slides, actually, if that's okay. So one of the things that we've been looking into at HYNEC is how people monitor their BP patients, their hypertension patients. So we would love to hear from you guys. So this will help us to identify if any PCNs practices require support in this area, or if you've got any areas of good practice that you were able to share. There's a link there to a short questionnaire. The questionnaire has also got a link in there to CVD Prevent if you wanted to kind of have a look at that. And the QR code's the same as the link as well. So would really appreciate any information that you've got that you can share with us. That would be fantastic. And also just wanting to kind of say how we can support at HYNEC as well. So we do have dedicated resources on our website, and we want to help support PCNs to identify undiagnosed hypertension, ensuring patient treatment is optimised. And so we do have some remote monitoring resources on there as well. So our digital team worked with some practices earlier on in the year, and those practices developed some pathways for hypertension monitoring. They both took slightly different approach of Savile practice and St Albans, and they devised some standard operating procedures. So please take a look at those SOPs if you don't have anything in place in your practice, and you can always adapt them for your practice as well. So just some resources there for everybody. Okay, sorry about that. And yeah, if you could give us a look on the questionnaire, that would be perfect. Okay, so just our contact details again. And then I was going to see in the chat, I think, Jack, have you answered some of the questions in the chat already? I know I think I tried to answer some as I went along. So I think there's one that can you answer this one, Catherine? It says, do you tend to refer on if systolic is greater than 140 and diastolic is greater than 90? Do you refer for treatment on diastolic above 90 alone?
So yes, to both of those. We want the blood pressure to be, I say as low as possible, but actually we don't want it to be too low. But yes, if both readings are, if you've got 140 over 90, greater than 140 over 90, refer, and also diastolic. If either reading is above the boundary, then we would want to think about treatment.
Perfect. And Sophie Turner's put on there, what are your thoughts on encouraging patients to monitor their own BP, for example, with their machine, and keep a record of that?
Yeah, so there's definitely a place for home blood pressure monitoring, and some practices are able to loan out blood pressure monitors. One of the aspects of the project that Jack and I did with the blood pressure kiosks was we had blood pressure kiosks in community centres, but we also had a number of blood pressure machines that could be loaned out. And the way that was set up was the community centre libraries were able to have those blood pressure monitors and loan them out on people's library card. So there's definitely a place for asking patients to monitor at home and record the readings. There's different ways of recording the readings. There's the traditional way of recording it on paper and returning the paper readings to the GP reception desk, and then it needs to be added onto the system. I don't know if there are some digital ways of recording this, but sometimes people, I believe, sometimes people can return the blood pressure readings digitally, which would obviously, the ideal situation would be to return it digitally and it to go straight into the clinical record. I guess.
Yeah, I think some of that's covered on the remote monitoring pages as well, Catherine. I know that some GP practices use AccuRx, and it sends reminders to patients to take the blood pressure and send those in. Yeah.
I guess the only thing to watch out for is the worried well. So somebody you wouldn't want, and it's important for people to be able to monitor their blood pressure if they can, but there are people that can't, for whatever reason, manage the blood pressure machines or worry about the blood pressure. So I guess the caveat to that would be, knowing the individual or making sure it was appropriate for the person you're asking to, if it is appropriate for them to monitor their own blood pressure.
Okay, thank you. We've also got a question to say, one of the GPs has asked to mention, are we to add 5 onto every home BP reading? So I think we've said if it was a healthcare professional, it would be 140 over 90, and if it would be considered high if it was 135 over 85.
So I guess you're still treating to the target.
Yeah. I think Catherine, we can't hear you, Catherine. Are you still there?
Oh, sorry. Oh, can you hear me now?
We can now, yes.
Oh yeah, sorry, apologies, my Wi-Fi's dropping in and out. Yeah, so sorry. So you're treating to target from the guideline targets, so the home blood pressure readings are often a little bit lower, and we would allow for that.
Thank you. It says, so can you confirm that the readings you have given us today are what we should be telling people, as we find that a lot of clinicians tell patients different readings and it gets very confusing?
So the numbers we've used today are based on the NICE guidelines, and that's the national guideline. So that would be what we'd recommend. Use something that's written down, and use a number that's written down in a national guideline. I think then if everybody does that, then we know where we are.
Yeah, thank you. And there's a couple of people asked, is there any funding available for GP practices to have BP machines available to loan out to patients? I know that there's quite a few practices do have BP machines that they loan out, and I don't know if that's been self-funded. Do you know if that's the case, Jack?
So, I mean, a few years ago now in the pandemic, there was the BP at Home program, which my understanding, this was before I came into this role, but the BP at Home program provided home monitors to a lot of practices. I don't know if it was all practices or what, but back then there was home monitors provided, and then I think since then monitors have probably gone missing from GP practice, from patients not bringing back, etc. But in terms of funding, we don't have any funding necessarily for BP monitors. It's something I can raise to the ICB that, well, I mean, GP practices are always going to be interested in more equipment, but we don't have any allocation for BP monitors, unfortunately.
Yeah, I think Natasha's put in there that that they've self-funded. So yeah. I know that Peter Horrocks has just asked if you could quickly brief everyone on the pharmacy service, if that's okay.
Oh yeah, thanks for that. Yeah, it's been great to hear you mention pharmacy service a few times there throughout the presentations. We've currently got about 90% of pharmacies across the North East and North Cumbria signed up to deliver the hypertension case finding service. And if a practice wants to know if the local pharmacies are delivering it, there's a page on NHS UK which you can do a search to find out which pharmacies are delivering that. But essentially, the service is in two parts. One is an identification and proactive service from the pharmacy. But very importantly, is if we've got a practice that has patients that need testing, or they're suffering with a shortage of machines, or patient doesn't have a home machine, they can refer the patient to the pharmacy for that check. And that's not just a clinical check; it's also an ABPM check that pharmacies can do as well. And just this year, we've had 60,000 tests done in pharmacies across the North East and North Cumbria area since April. So it's a service that's certainly there that is able to support the wider aims.
Brilliant, thank you, Pete. Okay. So it says practices don't have funding for BP monitors. Okay, but I think it would be welcomed if there was. And Blanca has put, would you use a different BP target following a stroke or TIA? I'm going to hand to Catherine for that one, possible.
So currently the NICE guideline doesn't stipulate that, but I believe there may be change in clinical practice, or that it's possible. I was just responding to Megan's initial query about different targets, but it may be that there's a clinical letter or a specific recommendation from secondary care asking you to differ from the NICE guidelines. So if that's the case, obviously follow the clinic letter for your specific patient. Otherwise, we would stick to the NICE guidelines.
Perfect. Thank you, Catherine. I think that's all we have time for today. If we haven't managed to answer any questions, we'll check the chat and we'll be able to get back to you. I just want to say thank you to Catherine and Jack for coming along today, and thank you for everybody giving up your lunch hour or your time today to come along and listen to us. It's much appreciated. Thank you.
Thanks, everyone.
Thank you very much.
Yeah, that was excellent. Thanks very much, guys.
Thanks, Barry.